Good afternoon, all. I'm going to present on behalf of Medicine 1. My topic is burn. So presenting Mrs. R, 24-year-old lady from Jharkhand, presented with the complaints of fever on and off for 1.5 years and generalized body pain for 20 days. She developed a fever which was high grade and intermittent and associated with chills and rigor and relieved by taking medication. And there is no evening rise of temperature. Her fever pattern was febrile for 3 days and followed by afebrile period for 2 weeks to 1 month. And there is a recurrence of fever is there. And he had a multiple admission and received antibiotics. There is no loss of weight, loss of appetite, and no features of autoimmune disease, and no comorbidities, and regular menstrual cycle. And she had a history of 2 spontaneous abortion, less than 12 weeks of gestation age, and delivered a preterm baby and at a gestation age of 34 weeks. And she also gives a history of taking infertility medication. So family history, there is an autosomal recessive pattern of polycystic kidney disease there. And on examination, patient was vitally stable and the febrile documented fever was 100.2 degree Fahrenheit. And there is no pallor, icterus, cyanosis, clubbing, and lymphadenopathy and pedal edema. And systemic examination were normal. So differential was considered pyrexia of unknown origin and malignancy and autoimmune disorder, disseminated tuberculosis and seropositive. So initial investigation shows there is a mild thrombocytopenia and other parameters are normal. And during the admission, patient had a fever spike. And at the time of fever spike, there is we did an investigation and it shows that there is further drop in platelet and ESR and CRP was elevated. And there is a mild direct hyperbilirubinemia with the alkaline pus was 221 and GGT was 803. And other autoimmune workup and cultures were negative. So patient underwent PET CT and this PET CT report shows that left liver lobe hypertrophy and borderline splenomegaly and multiple cysts in the both kidney and subcentimetric lymph node present in the deep cervical and para-aortic. And there is a one Mayberg complex seen and is suggestive of biliary hematoma. And patient was underwent RF scan and suggestive of fibrosis and MRI liver was done and shows wavy contour of liver and bilobar intrahepatic biliary radical dilatation. And there is a suggestive of congenital hepatic fibrosis. So we diagnosed as a intrahepatic biliary radical dilatation and focal carotid disease and congenital hepatic fibrosis and polycystic kidney disease. So I would like to talk about congenital hepatic fibrosis. It's a rare autosomal recessive disease derived from biliary dysgenesis and secondary to the ductal plate malformation. And clinically, it is characterized by hepatic fibrosis, portal hypertension, and renal cystic disease. And it's a dynamic and progressive condition. And it affects 1 in 20,000 population and it causes cholangitis. And there is the ductal plate malformation and there is an incomplete remodeling will be there. And it leads to there is a persistence of immature embryonic bile duct leads to excess proliferation of the fibrous tissue in the portal area that leads to the portal hypertension. So there is a 4 clinical form of presentation will be there. Patient can be present with the portal hypertension, cholangitis, and mixed form or latent. Latent is the most common presentation. It's mostly the asymptomatic and can be acute decompensated liver failure and cirrhosis. And there is a portal hypertension related features like splenomegaly, hematemesis, and melena. And patient is rarely present with the episode of cholangitis. That's usually is associated with the carotid disease and both the autosomal recessive and autosomal dominant pattern seen. And congenital hepatic fibrosis is frequently associated with the ciliopathy. Both the primary cilia and motile cilia is affected. So usual manifestation include infertility and recurrent abortion and polycystic kidney disease. And other organ involvement also kidney and retina and liver were involved. So this case study from China for a patient with a congenital hepatic fibrosis, the pregnant woman was delivered a healthy neonate. They suggested that so patient with congenital hepatic fibrosis who are pregnant, so she has to undergo upper GI endoscopy before the pregnancy or in the second trimester. For acute variceal bleeding in the pregnancy, managed by endoscopic variceal ligation and somatostatin. And risk include fetal growth restriction and fetal distress, fetal death, and preterm labor. And patient should be closely monitored by color Doppler ultrasound, fetal electronic monitoring. and choice of delivery is C-section. And a diagnosis of a patient by USG abdomen and MRCP, and gold standard was liver biopsy. And there is a typical imaging feature will be there in the imaging. So dysmorphic liver will be there. There is a hypertrophy of the left lobe and atrophy of the right lobe and biliary hematoma and Caroli disease and portal hypertension. In our patient, there is a hypertrophy of the left lobe is present and Caroli disease is there and biliary hematoma is there and portal hypertension in the form of splenomegaly. And so treatment, there is no definite treatment. Supportive therapy and the antifibrotic drugs and the cyclical antibiotic for cholangitis and ursodeoxycholic acid for the facilitate the biliary flow and portal hypertension, surgical intervention tried, and liver transplant for a severe disease. And the patient was a risk of having the hepatobiliary carcinoma. So patient should be monitored CA99 and alpha fetoprotein. So learning point. So patient was presented with the polycystic kidney disease. You have to suspect the congenital hepatic fibrosis. And if the patient with the congenital hepatic fibrosis is present with the recurrent febrile illness, you have to suspect the cholangitis. And so monitoring the congenital hepatic fibrosis patient, and there is a multidisciplinary approach needed for this patient. Thank you.
Okay. Dr. Kuthalaraj, can you just give me your final diagnosis? Thank you. Over to the audience. Any thoughts on this case? Okay.
It is a cholangitis. Cholangitis patient has present the cholangitis.
Okay. I had few questions. Let me just, we're dealing with a lady, no? Here?
Yes.
Okay. What was the SGOT and SGPT for this patient?
It's normal, sir.
Okay, it is not highlighted.
It's not. It's a one, sir. The SGPT was 22 and 70.
Sorry. You did an PET scan?
Yes, sir.
Only. MRI?
Patient is already undergone the extensive evaluation outside.
Did you do an only PET scan?
Yes, a PET scan and the MRCP was done.
MRCP was done. Does you used your title was burnt? Why was it burnt?
Fibrosis.
Oh, that's okay. The patient's presenting complaints were recurrent high-grade fever for 1.5 years.
Yes, sir.
And the second thing is generalized body pain. Does your final diagnosis explain this? Why did the person have recurrent fever?
Patient have a focal Caroli disease.
Okay.
So that will, whenever patient have a stasis, it leads to cholangitis.
So yeah, so it's cholangitis is a clinical diagnosis.
Yes,
it's a recurrent cholangitis.
Yes, sir.
And more than congenital hepatic fibrosis, it is the Caroli's disease which can explain that. Not the congenital hepatic.
Patient was present with the polycystic kidney disease.
Yeah, but the fever, the cholangitis is due to the Caroli's component,
yes, sir,
not to the CHF. They are associations.
Yes, sir. Yes.
So you have three things: CHF, you have Caroli's, and you have polycystic kidney disease. The part that explains the fever is the Caroli's.
That's correct.
Because that gets infected. So it's recurrent cholangitis. Yes, and the generalized body ache was a non-specific symptom. Okay. I wanted to ask you, you said about ciliopathy.
Yes,
so ladies can have ciliopathies, females? Because in gents, we have ciliopathy, no? I think it's Cartagena syndrome or something where you have ciliopathy. So in ladies, you brought up that as your discussion. Do women have ciliopathies?
Yes, sir. This
contributing infertility. That was one of your points, no? Infertility.
Yes, sir. Yes, sir. There is a case report from the congenital China, the pregnant woman with the congenital fibrosis.
No, I'm talking about ciliopathy. You put one of your slides with ciliopathy.
Ciliopathy, yes, sir.
Huh? So I was just trying to associate that with a lady, how that would come. Okay. Thank you so much for your case. We'll move on to the next one. This is titled Bequeathed. From Medicine 5. We have Dr. Ritesh.